Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
My name is Desiree, co-host of TopMedTalk and the Roundtable, and I'm here this morning with my co-host, Vicki Morton. She's Director of Clinical Quality Outcomes at Providence Anesthesia in Charlotte, North Carolina. Thank you,
Good
Vicki,
morning.
for joining me this morning as a co-host. We have here this morning Dr. Padma Gulur. She's an anesthesiologist at Duke and specializes in interventional pain management. Thank you for joining us this morning, Padma.
Thank you for having me.
Vicki, we talked a little bit about some of the questions that we had specifically for Padma this morning. You want to?
Sure. So psychological optimization with patients and getting them also better prepared for expectations following surgery regarding pain and pain scores. Can you tell us a little bit about that?
So I think that's one of probably the most important things we do in preparing patients is to first acknowledge that there's likely to be some fear and anxiety associated with the fact that they're undergoing surgery, and that pain and the pain they will experience is an important part of that. And the way we end up optimizing these patients is by first screening them. We try to recognize that not all people respond to stimulus the same way, different stimuli the same way. So we have some screens that we use that are well validated across the nation, which is fear avoidance, pain catastrophizing, the HAD score, which will help us determine if there's anxiety or depression playing a prominent role in their experience and how they relate and how they cope with different stimuli, and especially with pain, where it's been shown that patients who are high pain catastrophizers or they have a lot of anxiety or depression underlying, untreated, will likely not fare as well, in the postoperative period in terms of pain and recovery than others. We, depending on these screens and where patients fall with that, there's different treatment options that we can offer them, management options that we can offer them. And I separate the two between treatment and management, because treatment somehow implies that we're going to fix it, as opposed to management, which is really where we are, which is we can manage these conditions in a reasonable way so that it is not a detriment to their recovery after surgery.
So the patient, I just want to be clear. So the patients, they come to you and you do the screening. The screening is not done outside of you. So it's people who know the screening well.
Yes.
That's right.
Dr. Gulur, tell us about the clinic that you have
how it's set up.
Yeah.
So, there's a few different ways to do it. And in fact, interestingly, one of the questions that was asked just after the session was regarding this, which is, who do we allow into the clinic? I don't think of it as a allow into the clinic. We've set up the clinic to say, and the surgeons ask me, who can I send to you? Who do you think is, the appropriate patient to send to you? And what do you want me to do? Do I have to worry about how much oral morphine equivalents they're on? Do you only see patients above this? Or are there any screens you're going to make me do? And the honest truth is that they're not really specialists, especially not able to administer these more complicated screens or interpret them or do any of those requirements per se. So I really told them not to worry about that. The physician instinct, healthcare provider instinct, the front desk person can identify many times the patients who are likely to, not fare well over time, as they see these patients. So we basically told them, anybody, not just you as the referring provider, but anybody in your clinic, if they think that this patient could benefit from some additional support before surgery to optimize their, postoperative course, you should feel free to refer them to us. Once they come to us, we conduct these screens. Okay. Now I'll put one caveat, and this is a new development. We at Duke Health, are creating an integrated pain approach, and so that is not just perioperative. But what we will be doing is, if you as a patient enter our health system in any way, and your entry point could be cardiology, podiatry, you name it, wherever you've gone, your intake will include 2 to 3 questions, which again have been validated. So it's not a huge burden, where if you answer them, it will give you a flag which will stay with you in the system for pain as low risk, green, or not green. And what that will do is, if you're green, then standard care as we do business today is absolutely fine. And there's no additional thought that needs to be given to, supporting these patients further. So the reason I mention that is that if they're not green, they have to go through they actually are sent to a triage clinic, which will do more of these similar battery of tests. So as we move forward, even in the perioperative clinic, we won't need to do this because it'll already have been done in the system as these patients are coming through. But we will always have that option for those that perhaps didn't get it.
That's great. Identifying them early is key.
Is really the key, and providing that support all along. So we do conduct these screens for them then once they come in, and the way that it's conducted is essentially patient report. So we push these questionnaires to them before their appointment so they can do it. I would say that, it's not uncommon for them to show up for the appointment not having done it. So we then have a secondary mechanism where the person in taking them into the clinic can actually go through those screens as well. And we've chosen the screens carefully so it's not like you're answering, 60 to 80 questions, because every time you do something that impedes workflow and efficiency significantly, it's not sustainable. And it ends up being a poor experience for the patient. You lower your compliance, your adherence to everything. So all of these screens have been chosen very thoughtfully, as they actually give us information we act on as opposed to just data we're collecting.
Sure. So with your practice, you get the referrals of patients that are at higher risk for needing pain management or the psychological optimization, additional screenings. But you also have patients that are known chronic opioid patients in your clinic that are well managed. And so these patients that are scheduled for surgery and they're approaching surgery, you talked about an opioid wean prior to surgery and trying to get them down a little bit, but still managing their condition. So my question is, do you think that overall we need to be doing a better job if a patient has a chronic pain physician that they're seeing and the surgeon schedules them consulting with that pain management specialist and figuring out a plan for this patient, or if they're not seeing a chronic pain specialist, getting them, obviously, what you do into being proactive about that so that we can have a better perioperative outcome for these patients in a collaboration between the surgeon and the pain management specialist.
I think that's absolutely critical. And to be fair, though, you can absolutely work with their existing physicians and say it, but this is still early. This preoperative weaning and the benefits of it are not something that are people are not completely aware, and so they may not. It's not automatic. It's not something that and so sometimes you may need to actually help them understand why it's important, and then the providers will be happy to work with the patients. But you also need that education, because remember, just telling a patient to wean, you're not going to be successful with that at all. And so you really want the providers who are doing it have to be aware of the literature, understand the risks and benefits in an appropriate way, and be able to communicate that to their patients and educate them and support them. And that, I think, that the average chronic pain clinic, do they have the ability to do that? Absolutely. Are they currently set up to do that? Maybe not. And that's really where the crux comes in.
So, if you wouldn't mind, tell the listeners, you talked about how opioids can impact patients post-surgically. And when we think about side effects of opioids, we think of the normal things, constipation, nausea, all of that. But you talked about some things that probably a lot of people don't think about. Can you explain those, please?
Especially a chronic user.
Exactly.
Yeah.
For chronic opioid users, And, I will say that there's increasing awareness of this where now, there's advocacy for an opioid consent process, not just an agreement, for chronic opioid therapy, but a consent process. And a lot of the elements that we discuss with our preoperative patients are similar to that consent process. What I mean by that is, unlike, blood pressure medications, even the gabapentins, opioids, they do have a med safety label, and there's some side effects that are discussed with the patient. You're going to get constipated. You're going to get, you need to be safe in your dosage because you could overdose, etc. But they don't talk about the impact of chronic use, and that's not a labeling requirement, so it's never there. And that's the part where the consent and these conversations make the largest impact, which is sharing the information with them that opioids, chronic opioid therapy can impact your immunity overall. So you're almost in an immune suppressed state and therefore more prone to infections. You are more prone to your wounds not healing as fast. And both of those are extremely important after surgery. Both of those are things that are major concerns for us. So when you're in chronic opioid therapy and you go in for surgery and you have that, you're almost behind the 8 ball there. Your risks are higher because of it than the patient who's not on opioids. That resonates. They understand. It makes it real for them. Helping them understand that a lot of the, people associate opioids with a high and then the patient is defensive when they come, the chronic opioid user, because you think I'm just doing this to get a high, but you don't understand. I'm not getting a high. I'm actually low, if anything. And helping them validate that to say, we understand that. Chronic opioid therapy may not be giving you a rush at all. In fact, in many ways, you're probably not the same person you were before. You almost, and the families start nodding heavily at that point. You can just see it because they recognize that it's almost like a cloud, a weight is on them. You can almost tell the patient on a chronic opioid therapy because their slowed responses. Mm-hmm. They're not quite as, and their enjoyment of life and their, motivation, everything is down. And not to be motivated, not to be, all, again, puts you behind the 8 ball in recovery. Because if you're not motivated, guess what you're not going to do? You're not going to try to, get better. Could it have an impact on your mood in a negative way? Yes. And we're acknowledging that. We're recognizing it. Talking to them about, their hormone levels, the fact that it affects all of that and may have impacted their relationships, et cetera, because of it. Again, powerful education that patients, most of the time, it's like you can just see them just processing, opening up and saying, and some of them react by saying, why wasn't I told this before I got started on this therapy? Why wouldn't people have shared this with me? And that's really, powerful because you start to recognize how much they want the education. I think it's our responsibility to provide that information to them. And just like you would for a procedure where you explain the benefits and risks, when you put this therapy on, this is what I talk to my staff and my faculty about why we need to do this is it's your responsibility to ensure that you're educating them on these.
Well, and to that, so that's great for the patient education standpoint of it, but how can we better prepare the clinicians that are taking care of these patients perioperatively? Because there is sometimes a stigma, an unfair one, and we need to, I think, better help the clinicians understand.
I couldn't agree more on you. So we are also heavily invested in that prescriber and caregiver education as relates to these, medications. So while we're spending a lot of time educating the patients, these brochures and other things, we learn by doing. It's the best thing. I can put a bunch of health stream modules and force people to do it. But I'll tell you, I do the same thing. I go to the questions at the end because I'm just pressured. The work, where it is, I'm not going to go through all of that. So what we found is the most effective way of effecting change is actually as we do these recommendations, we absolutely make certain they're communicated to the providers, and then they see the results of that, and in the patients, and it's amazing how fast it's adopted. People are adopting it, they'll do it. Next time, I don't need to. Many times now I see patients who come to me where the PA and NPs in the surgical clinic have already, started the conversation with the patients to say, because they get the question, why are you sending me to this clinic? Well, I'm sending you because they're going to talk to you about this and they're going to give you alternatives because, and so it's amazing how it spreads. And that education, you're absolutely right, is important. But in many ways, the doing and just, you get started doing it, it's amazing how it spreads. Good news does spread.
Yes.
And good results spread.
Well, let me ask, Rick, how do we get a universal tool or education in the hands of the clinicians across the U.S.? I mean, what do you feel through your experience is the best way to have outreach to all of us that are on the front lines?
And honestly, it's programs like this that start the conversation, people who come, and then we have to publish this. We have to start, as the results come out, if you start publishing it, people will start to follow it. And so that's our responsibility, those of us that are doing it. If we don't share that information, it's not going to be very helpful. So I think, as you've seen, we just started this about a year ago. We're starting to see the results. It's now time for us to, get the word out and make sure that people can try it in their settings and see, what the impact is. And probably the power of open sourcing, it'll probably evolve into an even more powerful model as different people try it in different settings and find newer ways to do things.
One thing that I love about your clinic is you had said you follow these patients for quite an extended period of time, 90 days, correct?
Yes, that's right.
And really figuring out how it's impacting them long term. Right. And one of the things you talked about was that you've seen even further reduction in their opioid consumption use, which is fantastic. And can you tell us about that and why it's so important? And, we've been talking about population health this whole time. Right. And what does that mean overall?
As we talk about increasing opioid use, the burden of chronic pain, need for pain management, etc. One aspect, one trigger is surgical episodes or trauma or procedural. If you ask most patients who start on chronic opioids, they will recall an injury or an exposure related to that. So the perioperative period is an extremely important period for two things: initiation, but also using that teachable moment, because patients are very motivated when you are undergoing a life stress. So what an opportunity for us to not just how do you recover from this, but, maybe some of these skills that you are now more open to adopting could actually help you in the long run. And that's what we use the post-operative longer time that we have with them to reiterate, to say, you do realize that you were able to pull that off at a very stressful time in your life. And do you think that you could continue? And most of them feel, oh, yeah, it's actually not as bad as I thought. And I would totally do it because I am starting to feel better. And it's another rush. They're recovering. It's a good period again to feel good and feel like you want to do it. So I think that's been our benefit.
I look forward to reading your publications when
absolutely.
You get it out there.
We will.
Very much so. Thank you
so
for all
much.
the work you're doing.
Thank you. I really appreciate it.
Fantastic conversation.
Thanks for downloading and listening to TopMed Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMed Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website edpom.org/meetings. Our next big event is EdPom USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. edpom.org/meetings.